So my name is Andrej Spec. I'm an associate professor of infectious disease at Washington University in St. Louis. I'm um, I'm a fungal geek, so I do all things that branch and bud. And I'm the head of the invasive mycoses clinic here, as well as the currently I'm the interim editor-in-chief of Open Form Infectious Disease, and I am the lead author of the Comprehensive Review of Infectious Disease, which is one of our major textbooks.
Amazing. Do you like to eat mushrooms too?
I do. I actually also do go mushroom collecting. I am not as good at it as I wish I was, but there's many a dinners that have been had as a result of me walking through the woods.
Amazing. Wow. Okay. So today we're going to talk about fungal pneumonias, which is something we certainly see. Sometimes we just look at a pneumonia and we just assume it's bacterial. So I think it's important to talk about these fungal pneumonias. So maybe we could start by talking about why do you think this is an important topic for us to think about?
Sure. So fungal pneumonias are kind of where fungus starts, and then it often tends to spread. And there's been now growing literature that looks at how often we miss them. And Phil Polgreen did a study on histoplasmosis, and he estimated that somewhere between 80 and 90% of people who are diagnosed with histoplasma, eventually diagnosed histoplasma, have at least one episode where their diagnosis is missed. We had a similar study looking at cryptococcus, and patients with cryptococcosis have about 40% inpatient. So they're admitted as an inpatient with a disease that is compatible with their cryptococcosis, and they're not diagnosed at that time. So the story of having a missed diagnosis isn't an abnormality. It is absolutely the norm. And these are diseases that carry very heavy mortality and very heavy burdens of disability afterwards. Mortality for something like cryptococcus can be it's about 15%. And most of them some of the fungi can actually even be much higher in the 40s and the 50s and 60% range. And so what would be really helpful is if first-line responders who don't see these often got more comfortable with thinking of them, diagnosing them, or at the very least, just having them on their radar, because I think that would likely significantly improve the outcomes of some of these patients.
Love that. So let's run through the basic types of fungal pneumonias that we have to think about here.
Yeah. So most fungal infections start off as a pneumonia. Every day that you walk around, you're inhaling spores. Every breath, it's kind of like that Police song from the 80s. It's every breath you take. The day you were born, the first breath you took was full of fungal spores. And the day you die, the last breath you take will be full of fungal spores. And every single one in between will have it. And you may, depending on where you are in the world and what the weather conditions are like, you may be in a single day inhaling over 100,000 spores. And most of the time, your immune system just does fine. However, that's not always the case. And it's not always the case for people who have a completely normal immune system. When we actually talk to people who develop a more serious infection, which is how they usually get to me, by the time it's spread out of their lungs, if you spend some time talking to people, you will always get this moment of like, yeah, I had that cold 6 months ago. They said it was a pneumonia. I got like 2 or 3 rounds of antibiotics, but it just never really kicked it. It lasted like 4 weeks, 6 weeks, and then eventually got better. And then 6 months later, here I am with my meningitis.
Gotcha. Okay. So what I'm hearing is that most of these fungal infections are starting as pneumonias.
Yes. The only common fungus that doesn't start off as a pneumonia is Candida. All the other ones, really, that's how they enter. Histo, blasto, cocci, crypto, aspergillus, mucor. They all enter through the airways. And that's just because that makes sense, right? Our airways are in constant contact with the outside environment, which is very spore laden, and it's much less resistant to invasion than something like our skin is. You know, our skin is desiccated, it's dry, it's hard. It protects us much better than our airways can.
So let's run through that list again, that you ran through. What are the different fungal pneumonias that we could be thinking about?
So histoplasmosis is probably the most common one in America. That's kind of the classic Ohio River, Ohio Mississippi River Valley, although it definitely has moved into the East Coast, definitely all the way down to Florida and up to Vermont, really. And I am guessing it is more often missed there than it is here because people don't think to diagnose it. Then there's the blastomyces, which is more associated with kind of marshlands and more the northern Midwest, so like kind of St. Lawrence River, and again also the Ohio Mississippi River Valley, but also up in the Ozarks but not really crossing the Rockies. And then you have coccidioidomycosis, which is in the desert Southwest. But as we are having climate change leading to desertification of the American West, we're starting to see more cases up in Colorado, and going all the way north. You know, places like Oregon having wildfires due to drought would have been unheard of as little as 5-6 years ago, but they happened last year, right? And so that's the kind of environment that those three kind of exist in. Then you have Cryptococcus, which is much more of a cosmopolitan fungus. It's present in kind of just about everywhere, but the West Coast has a probably more virulent form called Cryptococcus gattii. And fun fact, it's actually a de-evolved mushroom. So Cryptococcus is genetically much more closer to your button mushrooms than it is to the other fungi that cause human infection. So in specific conditions, you can actually make it form a gilled mushroom. The other ones that we look at are kind of the more ubiquitous mold, Aspergillus, Mucor, and then there's a smattering of about 100 other species of molds.
So Aspergillus and mucormycosis are just sort of, they can be found anywhere.
Nobody has ever really done those studies to look at where their prevalence is. They certainly have some places where they're more common than others. So for example, India has always had a 70-fold higher rate of invasive mucor than the rest of the world, which isn't surprising because mucor likes hot, humid weather, right? Which kind of describes India pretty well. But it is basically everywhere.
Okay. All right. So we went through those different types of fungal pneumonias, and sort of location-based where we might think about them. How else, like what other types of patients or clinical scenarios should we be thinking maybe this is a fungal pneumonia?
Definitely patients who have defects in the in immune systems. So people who and there you kind of break it up into two. So there's the endemics, which is the histoblastococcus plus crypto. Those four tend to be more associated with adaptive immune defects, mainly T cell defects. So that's a lot of immunosuppressions like steroids, transplants, HIV. Those are things where those tend to be more increased. And then Aspergillus and Mucor tend to be more associated with, well, also transplant patients, but more people who have neutrophil defects. So people, neutropenic patients, cancer patients, people who have inborn errors of neutrophils, things like that.
Okay.
And you can, but keep in mind that all of these have immunonormal hosts. So even Cryptococcus, which we talk about as one of the it's a defining disease of HIV, 300,000 deaths a year from Cryptococcus in Africa alone associated with HIV. here in America, about 15 to 25% of all cases are immunocompetent people.
Okay.
So it's important to know that literally it can be anybody.
It can be anyone, more likely to be immunocompromised, but we can't rule it out just because someone has a theoretical immune system. Okay. So we've got our locations where these things may be more prevalent. And we've got our patient population where it may be more prevalent, but then again, there's climate change changing all those locations. And then there's immunocompetent people who are getting this as well. So it just becomes complicated. So in such a world, right, how are we going to go about making this diagnosis? What symptoms are we going to see? What findings are we going to have on chest x-ray, lab values? I don't know.
Absolutely. So, if you focus on the pneumonia, which is what you're going to see mostly, a few things should tip you more into that direction. So one of them is when you have multilobar pneumonia, right? So fungus is more likely than bacteria, but to be multiple places. Usually with bacteria, it's a single solid lobe.
Which also we could think about with atypical pneumonias too, would also sort of be multilobar, right?
Correct.
Okay.
Correct. And viral, virus does the same thing, but it makes it, that's one of the things we look for. The other thing is that the appearance, usually on CT more than X-ray, is when you have nodules with surrounding ground glass, and that surrounding ground glass can be very faint. And then the other thing you look for is reactive lymph nodes. The reactive lymph nodes appear to be very prominent in fungal infections, more so than in bacteria, because especially like classic bacteria, pneumococcus, they just pop up so fast that there's so much neutrophils just going into that area that they don't necessarily have a massive proliferation of lymphocytes in the lymph nodes already. So that's the other thing that you look for, a longer course of duration. And then the thing that is very helpful, which is where I think we can really help people the most, is people who have failed antibiotics. So if they've gotten a course of azithromycin, gaining not a huge amount is gained by doing another course of levofloxacin or a longer course of azithromycin, which is usually what we see. We see, they failed levofloxacin, so let's give them augmentin, or because the amount of bacterial isolates you're really picking up by changing from those common pneumonia drugs isn't huge, but there's a lot more to pneumonia than bacteria, and fungus is often a pretty common one.
Okay, that makes a lot of sense. So just to recap that, if it's multilobar, we should think about it if there's huge associated lymph nodes, if there's nodules with surrounding ground glass appearance, which would probably be seen better on CT. But most importantly, if this is something that has been going on a while and maybe even got a course of antibiotics that didn't really respond, these are the things that should be making us think about fungal pneumonias.
Yeah. And it's probably unfair to ask somebody in a busy emergency room, especially, like our emergency room, which will often have like a 10-hour wait, to be able to go into the minutia and diagnose these things in detail. But what might be helpful is an early referral to infectious disease doctors. If you see somebody who's failed one or two courses of antibiotics and you're not necessarily sure what epidemiology you're looking for, what the risk factors are, a early referral to somebody who can evaluate that, an ID physician who can evaluate that, might be very helpful to these patients, because really the goal is to prevent dissemination. Right. Most fungal pneumonias aren't lethal in and of themselves, except for in the neutropenic patients, but in the truly profoundly immunosuppressed, like advanced HIV, it's the dissemination that then tends to cause problems.
Now, clinically, these patients will present the same way: fever, cough. I mean, it won't look any clinically different than a regular pneumonia or bacteria.
A lot of times we'll see more weight loss. And the reason that we see it is just because it lasts longer.
Okay.
If you have acute pneumococcal pneumonia, you're 3 days and you're sick as stink, and you really haven't had enough time to lose weight. Whereas if you've had your histo for the last 3 months, you may have lost 30 pounds.
So it's a little bit more indolent, maybe, in insidious onset. Okay. And how about, are there any lab values that would be interesting to look at for these type of things?
Once they get disseminated, yes. I haven't really found any labs that have kind of in the pneumonia stage that really kind of set you off, unless you really start to go into the world of fungal serologies and very directed diagnostics, which is a field that's probably changing and highly nuanced. And to be honest with you, my experience has been that unless you really dedicate a lot of time to learning those, you're more likely to use them wrong than to use them right.
Okay.
And we see this all the time, even in our own field. They're not the perfect tests,
Right.
and so they really require a lot of knowledge to be used.
Okay.
Other than cryptococcal antigen. The cryptococcal antigen is probably the only test that I can endorse people almost get willy-nilly. The cost, it's a lateral flow assay. So in most cases, it's a lateral flow assay nowadays. And that means it's a pregnancy test. It's a dipstick with a line. It's dirt cheap. I think the Medicare reimbursement, the last time I looked for it, was $18 for it. So we're looking at, cheaper than getting a CBC or a CMP.
And this is a sputum test or blood test? Blood.
Serum.
Okay. Serum. Okay.
Cryptococcal antigen in the blood, and it's the sensitivity is around 99%, and the specificity, depending on your population, is either in the mid 80s to high 90s.
Oh wow! And that's for the pneumonia, not for a disseminated cryptococcal infection.
It's much more sensitive for disseminated disease, but even in pneumonia, it's actually pretty decent. And so if it's positive, it's 99% specific. Thank you. That's the word I was looking for.
Okay, interesting. So cryptococcal antigen could be useful, but of course that's just one of five or six, or if not many more potential fungal pneumonias we could be thinking about.
Correct.
But
so I think this is where your friendly neighborhood ID doc is always helpful.
Okay. Okay, great. And maybe we think about that more in the HIV patient or something like that. That may be a high likelihood.
And then the other place where I think cryptococcal antigen is very helpful is in cirrhotic patients. So people who have cirrhosis have actually a very high rate of cryptococcosis, but we don't think of it as having a high rate, and their mortality is actually really high. Most cohorts have had their mortality north of 80%. And that's because we diagnose it very late. Usually what happens is nobody thinks of it. And they keep getting admitted for a pneumonia, or it gets blamed on SBP, or they get blamed on, they get altered. So it gets blamed on hepatic encephalopathy. There's a lot of diagnoses that aren't super difficult to diagnose. There's not a test like pins it down and they say like, well, that's definitely what it is. And so they get a few admissions that way.
But this is starting off as a pneumonia in these patients as well.
It starts off as a pneummonia and eventually progresses to dissemination. And in that situation, the test is great, because I gave a bunch of lectures on this, and a lot of our GI fellows have now started doing it. And for the last few years, I've been seeing a lot of them caught early and doing well.
Oh, wow.
Because they keep getting admitted, they keep getting admitted for these different things, and eventually they'd have meningitis, disseminated disease, and they have 80+% mortality. Whereas now we've been getting much better at this, and they keep getting caught early at the pneumonia stage or at the very early dissemination stage, and they just respond to therapy better.
Okay, so cryptococcal antigen print seems pretty straightforward, and that should resolve if somebody has been cured. In other words, like you treat it, the antigen should theoretically go away.
No. So cryptococcal, that's the downside of the cryptococcal antigen, is that it can persist for a very long time.
Okay.
Because it's actually the capsule of the yeast, and the capsule is huge. And that can persist in the blood for a very, very long time. And we have people who have, 5, 6 years out of therapy, and they're out of therapy and they're doing fine. And I see them once a year and they've had positive. Somebody will eventually check their antigen after 5 years and it's positive.
It's still positive. Okay. All right.
Not always, but often.
Okay. So let's say, we've got, and again, we're in the ED, things are moving fast. We don't have too much time, but let's say that story is turning out to be, it raised our suspicion. Person's had antibiotics, amoxicillin, didn't respond, has some multi-lobar findings, has some weight loss. So now we're thinking fungal pneumonia is pretty likely. How do we treat this?
So there's different ones that you treat differently, but if you have a crashing patient, somebody who looks like they're going to have ARDS, they're going to, they're progressing towards intubation. Usually the drug that kind of covers just about everything is amphotericin. Now amphotericin is a difficult drug, as you may remember from the nicknames that it had in the past, amphoterrible. The newer formulations are definitely not as bad as those, but it is a drug that should be given with some caution, reservation, and experience. And in many places, it's actually restricted to ID use only. So that would be one of those situations where if you see somebody who's, they've failed a course of antibiotics, and they're progressing, you see these kinds of findings that are kind of hinting towards a fungal pneumonia, that might be the time you call your ID fellow on call, or your local ID doc, and say, hey, I think it's time for us to give a dose of Ambisol. And they could probably help you with the dosing, because again, the dosing gets complicated. Although 5 mg per kg, if you're out by yourself, don't have access to anybody to help you, 5 mg per kg is a good number to remember. Just make sure you do ideal body weight or adjusted body weight. You don't want to necessarily give 5 mg per kg total body weight to like a 700-pound patient. That could be really bad in terms of side effects. But it's a good number to remember. 5 mg per kg.
The patient that's coming in, the patient that has pneumonia that's going to require admission, that they're going to have to come inpatient, they're probably going to be getting amphotericin for that, and that would cover all of the potential fungal pneumonias.
Just about. There's a few resistant ones they're kind of really rare.
Okay.
But amphotericin is kind of it's the broad spectrum antifungal.
Like the Zosyn of antifungals.
Yeah, it's kind of like the Zosyn. It's Vanc and Zosyn.
No.
There are some isolates that you're going to miss with Vanc and Zosyn, and it probably damages the kidneys as much as Vanc plus Zosyn does.
Right. So that's like a renal. That's the one where there's a lot of renal side effects.
There's two main things you worry about. One is the renal toxicity and the associated electrolyte wasting. The other thing you worry about is infusion reactions. During the infusion, people can get, fevers, pain, sweats, those kinds of things.
Okay. All right. So we talked about one drug that's a pretty big gun. That's for inpatient. And that's something we'd bring ID on board if we're thinking about it. What else?
The nuances the funny thing about fungi is we only have three classes of drugs, and of those 3 classes, one is basically just that, it's ampho. The other classes, one of the other classes that kind of canons is basically just there's 3 drugs, but they're all the same. And then the other class gets really complicated. The azoles get super complicated super fast. And I would say they are probably not super helpful in the ED.
Okay.
Because most of the azoles that we're using for molds take 2 or 3 days to start working. and you really shouldn't have the patient down there for 2 to 3 days.
What if there is there a scenario where, you know, someone has these type of things, we'd like to, you know, they're not sick enough to warrant admission, so they're going to go home on something and probably follow up with ID, but is there something we could start in that meanwhile, or is it more, it breaks down into too many different categories?
It breaks down really fast into too many different categories, and you need to know which one it is, which really depends on your local epidemiology and other very nuanced risk factors, and you need to do a lot of serological testing before you decide what it is.
Okay.
So I would leave the initiation of azoles up to the referral in the ID clinic. And really, I think the best thing we can create for these patients would be kind of a systemic, quick pipeline where, you know, you can get them into the ID clinic within 3 or 4 days or a week or whatever, as opposed to having to wait. Sometimes, you know, like my clinic is usually booked out like 8 to 12 weeks. But if I hear about these kind of urgent cases, I will overbook myself. But it's really about creating that pipeline so that the patients can be seen quickly.
That makes sense. So I think really what it's about is sort of raising that flag of recognition. We may not initiate treatment in ED or outpatient clinic, but, you know, we want to get them in to be seen somewhere soon to get that workup done. So what are general outcomes for these fungal pneumonias? You kind of mentioned that a lot of them do progress to systemic sort of fungal infections, but how does it go if it's treated? You know, yeah.
So if it's treated in the early stages, it's a long course of treatment. It's usually measured in months, not days.
Oh, wow.
So most people will never treat less than like 12 weeks.
Wow.
So which is part of why I'm saying, like, you don't want to necessarily just be starting something, especially because these azoles are also very expensive. Some of them can be $8,000 to $10,000 for a month course, and getting those approved by insurance is a bear. And so you're treating for a prolonged period of time because fungus just takes a long time to die. But if it's caught early, the outcomes are actually spectacular. Very few people will die of where it's just localized pneumonia. There are cases, blasto classically will cause a community acquired ARDS, kind of the way pneumococcus does, where they come from the community and they just come in, their lungs are trashed, and they're going to be intubated in the unit, they're intubated in the ICU. But most localized pneumonias tend to do pretty well.
Gotcha. Okay. Anything else that I didn't think to ask or that you think is important?
Sure. So I think the biggest thing that I like to tell people about this is that fungi are not as rare as we think they are. It's just that we miss it a lot. And so most of us and I was included in this before I started working on mycology, would say, like, I don't see mycology almost ever. We just missed it. And there's been cases that I've come back to from residency and from early in the fellowship where I didn't think of mycology, and they turned out to have a fungal infection. And it still happens to this day, but it happened a lot more before. They're pleomorphic diseases, and they can be difficult to diagnose, and so they should just be kept on the radar pretty heavily.
Love that. Thank you.